like they could, I think, at least $6 billion per year. Yeah, so as I said, there are many stakeholders like payers, providers, of course, hospitals or physicians, or and patients and regulators or policymakers. They are all interested in information from this process. And different types of providers include like hospitals, physicians, or some like organ procurement organizations. If you are familiar with organ transplantation, this is actually this is important type of providers. And transplant centers, of course, physicians, surgeons, many different types of providers. And this is actually a high stakes process because if, say, we identify certain providers who are underperforming than the national average, say, it would be that there would be some consequential issues, events happening. Say the provider could be decertified from operation, like it will be totally gone, or it could be forced to merge with other. Oh, I need to look at
No,
this
are you mute?
Oh, I'm muted. Do I need to?
I'm muted.
Okay, sorry.
I'm mute.
Okay. Sorry. Do I need to start over again? No?
Yeah.
Keep going?
No.
Okay, sorry.
Keep going.
Okay, so yeah, so those underperforming providers could face very serious consequences. They could be they could also be forced to merge with other providers, like institutional providers, I mean. And it's actually very common to do risk adjustment models in this process. And a lot of papers actually have been focused on risk adjustment models in this field. But we will use and a lot of people develop standardized metrics to basically either rank or score different providers. So basically they will say we can do 5-star rating, and we have 5-star hospitals, 4-star hospitals, or we can do a ranking, or we can basically identify some outliers, either very good, either providers with very good performance or like very bad performance. So there are different goals, many different goals in provider profiling, like accountability. You wanna hold providers accountable if they do not perform good, well, and of course, like agencies like CMS, they want to save some money. So cost effectiveness is also a important goal. Of course, quality of care and equity. Of course, for policymakers, they need information to inform their decisions. And of course, for patients, being hospitalized, if they receive certain procedures in the hospital, they need to know whether, say, certain operations are safe or not for them, right? So many different goals under this provider profiling process. So this is an example, a recent example from JAMA, original investigation. I think it was published last year. So they basically did evaluate. They evaluate, I think, about 3,000 hospitals across the nation. They want to evaluate readmission as the outcome, and they consider equity as an important perspective. So I think on in panel A they use Medicare, Medicaid dual eligibility as the equity factor, and in panel B they use, I think, race as the equity factor. So they basically identified, I think, about one quarter hospitals who are better performing than the national average, but they tend to treat patients who are I think who has better health than other hospitals. So there are some I think risk adjustment issues in definitely in this process, and some prominent profiling programs in the nation. So the first one is the state level profiling program. It's actually under the New York State Department of Health. They have been doing this for, I think, 40 years-ish. So they have been evaluating different hospitals and the surgeons in the New York City state, actually. Uh, those hospitals, they're doing, I think, different types of procedures for for patients with cardiovascular disease like CABG and PCI. So, and another three, number 2, 3, 4, those three are basically nationwide profiling programs. They're all under the umbrella of CMS. So they have been, I think, ongoing for at least 20 or 30 years. These are all like very important programs. So this is actually a CMS website. I think this is called Medicare Compare. Medicare Compare, yes. So as you can see here on their website, they listed many different types of providers, I believe, doctors, hospitals, nursing homes, like hospice, rehabilitation facilities, and dialysis facilities, many different types. So this is actually designed to provide information to patients so that they can identify the best provider they want. So, and a lot of information has been used here as well. And I just want to list a few papers here in hospital profiling. So there's quite a few high impact journal papers in this field, and mostly focused on the hospital readmission reduction program under CMS. There are also papers in physician profiling. Basically, you want to evaluate physicians. And this actually is an important report published by the Massachusetts Medical Society, which is the publisher of the New England Journal. They even report some important principles for doing this. And this is actually, so on the left is a analyst paper, but it was actually written by two statisticians. Yeah. So the title is Improving the Statistical Approach to Healthcare Provider Profiling. It's a note paper, I think 1997-ish. But they have been, I mean, there are people who are very interested in improving the underlying statistical methodology in this field. And on the right, it's I think a very important white paper. It's not a journal article or something. It's a white paper, but it was written by a very special committee. So I think nearly everybody knows COPS, right? The Committee of Statistical Presidents of Statistical Societies, right? So this white paper was commissioned by by COPS and also by CMS. And I think in the paper writing committee, there's Tom Lewis is there.
Tom Lewis was there.
Yeah. So Tom Lewis was here. I think he retired, right? Yeah. But yeah.
He's retired.
Yeah, Tom
Still
Lewis.
acting.
Okay, yeah. Yeah, but I think he was involved in this. This is also a nice reference about some of the statistical issues in provider profiling. So this is a yep.
So currently, what kind of data are they using to profile the?
So I think for those nationwide programs, they use mostly claims data. Like CMS, they have the Medicare claims. Yeah. And I think some regional or local hospital programs, they also use EHRs. Yeah. Yeah.
So they don't collect anything more than the secondary routine you collect with the UHR.
Yeah, I don't think they collect any data on purpose. I mean, claims are not designed for this process, right? They're basically for billing purposes. So of course there will be a lot of, bias, because, insurance companies, they want to earn more money, right? So yeah, so it's definitely, there is definitely bias. But yeah, so I think for big programs, they use a lot of claims data.
Okay.
Yeah.
Okay.
So yeah, so this is basically a quick summary of the current literature, I believe. So I think the most widely used type of models is hierarchical random effects models. I think arguably proposed by Sharon Lees Norman in 1997, maybe with Konstantin Gasanis. Yeah, so the couple, the power couple. Yeah. So yeah, so they have, I mean, along the line, a lot of papers have been published using the random effects models, and a second line of methods is fixed effects models, basically what Kevin and Jack did at Michigan, and I think Damla Shenturg at UCLA, they also do some fixed effects models. And also, well, the third one is not like mutually exclusive from the other two, but they considered competing risks, semi-competing risks, recurrent events, a lot of other, time to event data types. And I think Sebastian Anus at Harvard, they have been working on this, and also Francisca Dominici, I think she is also involved. Yeah. And of course, Sharon Lees. The last one is sort of I think a relatively new group of papers. They considered sort of using causal inference or clustering to address the profiling problem. So in today's talk, I want to basically discuss, I think, two limitations. The first one is I think people have been heavily relying on the linearity assumption in many of these models. So this is the example. This is a figure from one of my recent papers. We simply examine the variation of the effect of COVID-19 on 30-day hospital readmissions, unplanned hospital readmissions among Medicare beneficiaries with end-stage renal disease. So they are on dialysis, and we have data in I think the COVID year 2020, the first 10 months. I guess the font is a little small, but so on the left, this surface plot, we have, I think, on the x-axis, days since discharge. So we are looking at the 30-day window, and this y-axis, we have the dates, basically the calendar time in 2020. Yeah. So on the z-axis, we have the hazard ratio, I believe. Yeah. So basically, you can see we're only looking at the effect of COVID on the binary outcome. So as you can see, it's very dynamic across two time dimensions. So this actually suggests, if you otherwise use a linear model, whatever linear model to fit this is just not realistic. This is not going to work. I want to give you a little bit of the model setup. So let's say we want, we have, say we have outcomes. We have, of course, we have a column of like provider indicators, and we have like a bunch of covariates we want to adjust for. And the model we want to consider, this is the outcome model. So the model is looks like it's very simple. So this is basically the expectation of the outcome, and we write this as h is a length function, basically is increasing and differentiable, and this omega star is basically a predictor, and we define this.
Can you give a quick example of what would be the typical outcome?
Oh yeah, it could be a say length of stay is a continuous one, or it could be like
stay in hospital,
right,
or okay.
Yeah, or it could be like 30-day hospital readmission is a binary one.
Okay.
Or well, I haven't considered time to event outcome, but of course you can do that. Like if you want to consider, say, hospitalization, it could be like a recurrent event, right?
Okay.
So well, this may not fit the recurrent event setup, but this is I think a very commonly used model.
Okay.
It's nothing fancy here, but let's say if this h is a logistic function, then f omega star is just a linear,
Also ask just a follow-up quick question.
Yep.
So for y, is that an individual level outcome?
Yep, individual level. Yep. Yep. So if say this omega star is written as this is basically an indicator of providers. So this is basically a vector. So I will share later why this is -0. So basically this vector we only include indicators of f equal to 1 and 1 through f equal to m, but we drop f equal to 0. So f is could be 0, but we didn't include that. So let's say here, we have a linear predictor. So this is basically, these are basically provider specific effects. So gamma star is a vector of provider specific effects. This is a beta 0 constant, and we have, z beta here. It's a very simple setup. So let's say if the linearity assumption is true, then we can simply run a logistic regression here, right? With fixed effects, and you can do estimation inference without any problems, I believe. That's very standard. But let's say here we want to relax the linearity assumption. So now it becomes, okay, the second part, the beta 0 plus beta z beta, it is some sort of unknown nuisance, possibly nonlinear complex function, G star here. So if we have this set up, then the estimation inference could be very challenging. So one issue, I think you might want to use some more flexible machine learning methods to address this. Yes, you can do that, but that's not good enough, unfortunately. So basically, if you use, say, I think a simple solution would be, okay, you fit a deep learning model, neural network. But here you run into another issue. The estimation of R star would be seriously highly biased. So this is because so basically from this model, this simple outcome model, we can have this basically estimating equation. So this basically is a score function, conventional score function. But this score function, the problem is with the scores functions, it's very sensitive to estimation errors when, let's say, this G star was estimated poorly. If it is seriously biased, then the estimation of gamma star would suffer as well. So how to address this? Rather than using the conventional score function, we have to rely on the so-called Neyman orthogonal scores.
So when you say estimation error,
Mhm.
are you talking about measurement error?
No, when you want to give
were
the
just talking about-
point estimates of
Or you
gamma
for
star.
estimation error in the estimation?
Right, it's highly biased. Yeah, it'll give you biased estimators.
So from this specification,
No,
just from randomness.
no, it's because the second part is nonlinear.
Or because of the model assumption, right?
Yeah, this is a partially linear predictor, right? This omega star. So you can use a deep neural network model to fit this. And the second part, of course, it could be very well captured by the neural network, but in terms of this gamma star, the estimation is very bad. Yeah.
And hospital.
Yep. Yeah.
And you try to combine the other things into this nonlinear nuisance G star.
It's like we're gonna fit I would talk about that later. But we're gonna fit a double debiased machine learning algorithm and involves cross fitting. Yeah. So, yeah.
So I'm still a little bit confused. So
Mhm.
you're saying that this score function is sensitive to the bias in G star.
Yep.
Yeah, but you're saying that even if you use very flexible model for G star, we have problems.
Yeah, because it's hard to have a very good estimator for G star, even if you're using very flexible black box, deep learning models.
Because of sample size.
We have some like numerical experiments results. Yeah.
Because I mean, given enough samples,
I don't think it has anything to do with the sample size. Yeah,
So it's really the method, deep learning.
And suppose they did anything.
Or it's possible like overfitting things like.
Yeah, overfitting could be, yeah, because, in neural network model, you have to do, like early stopping or whatever other, types of like drop out. You have to somehow stop early.
Stop. Right? The method is not good enough
Yeah,
to handle.
I think we have similar, but not the same model, but it's like similar setup. It's like when you fit like two flexible models on one part, you basically absorb all the signal
Right.
to that part. So
Yep.
you actually lose the signal from the main part, like here, the gamma cell.
Right, yeah. So if you have, as Yanxun said, if you have a very flexible model, your estimation of, like, in this case, gamma star would be very biased, basically. So we have to rely on a different type of score functions called Neyman orthogonal scores. And this one is actually very good because it actually is relatively insensitive to any deviations of like whatever estimator G from the true nuisance functions G star. So this is
Orthogonal scores.
it's actually I'm going to talk about that. Yeah, it's not actually it's not a new concept. It was, I mean, as the name suggests, it was actually proposed by Jerzy Neyman like many years ago, 1950s, 60s.
Which was 1981. And that's the year he died.
Oh, wow.
Mostly name it.
Yeah, that's from Jerzy Neyman, right? So here is the definition. It's a little technical, but so the simple idea is, okay, we still have the zero mean moment condition as what we have in the conventional score function. But addition to that, we need to have we have another type of like first order conditions. We need to use Gateau derivative, which is like it's, if you are familiar with differentiation, directional differentiation, this is sort of that type of derivative. It's a little complicated, but this is the definition. Of course, there's a lot of theoretical details behind this, but I'm trying my best to give you like a rigorous but short definition. So we can construct, actually, this is a very challenging step. So we can, using because we already have the outcome model, we posit this outcome model, and I think we also need another model, which I call choice models, but we'll talk about that later. So we actually need two models for this task, but with that two models, we can construct Neyman orthogonal score functions. So this is this is the one of the Neyman orthogonal functions we can use. It's actually not easy to come up with a Neyman orthogonal function in practice. So this is for a general type of outcome, like it would work for any longitudinal outcome, I believe. But if you have a logistic, a binary outcome with a logistic link function, then the other Neyman orthogonal, the other score functions would also be Neyman orthogonal. At, of course, gamma star and eta star, they are like true values. Yeah. So basically, our approach is like, okay, we want to first, for the outcome model, we want to fit a neural network, deep learning model. So this is like feed-forward neural network, but the outcome layer is a little different. So this is actually a scalar, and we need to add the provider specific effects into the outcome layer only. So it only appears in the outcome layer, not in the hidden layers or any other way, any other position. So the second model we need is a choice model, or you can say it's like a propensity score model. Basically, it tells you like given certain patient level characteristics, what is the likelihood that the patient got assigned to a provider, or you can say the patient chose a certain provider. So that's the second model. And we can fit a second neural network model, but now the outcome layer is different. Now because we basically need predicted probability, so we need a softmax activation function to give you like, different types probabilities for different categories, right? Or different providers. So this is basically a quick summary of, I know this is kind of busy. Yeah, so I think, so for the input data, we need, the data structure is quite straightforward. We have outcome, we have the provider indicator, and we have a vector covariance ZI. So to proceed, we need actually a nested K by K fold random partition. It's not like a typical, well, it's like a typical K-fold cross-validation when you partition the entire data set into K-folds, right? But for each fold, you need to do that. You need to do that again. So it's like K by K fold. So doing this, you can do the cross-fitting procedure. So basically, the first step would be for each. Let me call it subfold. For each subfold, you fit two deep learning models, right? And you get provider effect estimates, and you get the G hat and the D hat. But at this time, at this moment, those G hat and D hat, they are only for those subfolds, or we only train those models on the training subfolds, and we have one fold left behind. So we need to apply the fitted model to the. I think would be better to do this. So let's say initially we have, let's say we start from D. So we will have D1, D2, D3 until DK, right? And then for D1, we'll have D11, D12, D13, and the D1K. So basically for fold 1, basically for D1, we need to use D12 through maybe D1K. So those K minus 1 folds, we use those folds to train the model, two models basically. Then we get G hat and D hat. And of course, we also get gamma hat here, but as I said, the estimation would be very bad. But the point is to leverage G hat and D hat for the next step. So we basically calculate the partially linear predictor here on the D11 fold, and the same thing for the outcome model. This is also the basically I think it's a matrix of predicted probabilities, and then we use these quantities. We can do least squares estimator here, and we can get a second step estimator for the provider effect, and this is still not the final one. And the next one is I think we go one layer above. We fit a third deep learning model, but this time the deep learning model is very similar to the first one, except that the outcome is in a different scale. It's in the age inverse scale. Originally, we have the age of the partial linear predictor, but now we need the partial linear predictor itself without age. So it's in the age inverse scale. So this is a third deep neural network model. And now we have better G hat here. And of course, we have this D hat. So finally, we need to rely on the whatever Neyman orthogonal score we have. And we plug in those neural estimated nuisance functions. And basically, this is, I believe it's a multi-dimensional root finding process. Yeah, depending on like how many parameters you have. So the last step is basically a root finding algorithm. You can use, I think, many common like multi-dimensional optimization algorithms. But this is basically a quick summary of the of the double bias machine learning model or deep learning model. Any questions? Too much technical detail? Yeah, go ahead.
Well, like problem is that part of the like what's the relation between like the G function and the like G hat that we had.
So I think the final de-estimator that we're going to use in the Neyman orthogonal score estimation equation is basically this one is actually simpler. So we only need the you do a k-fold random partition, and you can do this like a cross-fitting, very cross-validity. You fit the model on say k-1 folds, and you use the left one to do prediction. Yeah, basically. But I think the challenge part is for the G. So G hat is very difficult to fit here. And you have to do this iterative process to get a good estimate of gamma star. Basically the provider specific effects that we're interested in. Yeah. But the last step is actually not very involved, because basically we plug in everything we have regarding the nuisance part, and so if you treat gamma as a as a unknown, then it's basically you solve the of course it won't be linear, but it's a basically a estimating equation you want to solve. Yeah.
Do you assume each provider have same X?
You mean the same set of variables?
Yeah, same set of.
Yeah. Yeah. All right. Maybe let's move on.
Maybe foundation.
Yep.
Is non-orthogonal for related to doubly robust method?
Yeah, good question. So, yes or no? It depends. So the first one, so it's a general Neyman orthogonal function, I would say, but unfortunately, it's not doubly robust. But if you look at the last one, specifically for a binary outcome, it's actually doubly robust. Yeah. So it's basically, let's say if D is misspecified, or if the other part, the G, is misspecified, either one, the estimation would still be like consistent. Yeah, in certain sense. Yeah. But the first one, no. Yeah. But the first one is like it can accommodate many different types of outcomes. But the last one is only for binary outcome. Yeah. So it's yeah, as I said, it's very challenging to come up with a good Neyman orthogonal score function. Yeah. Okay. I move on. Okay. This is basically a short summary of some asymptotic results. So of course with certain regularity conditions, but of course we need to assume that we have a Neyman orthogonal score function, and of course the two models, the outcome and the choice models, they are true both, and we can have some large sample nice properties. Of course we have the normality, asymptotic normality property, and a sandwich type of variance matrix, variance covariance matrix estimator is also possible, but the theoretical details actually it's very hard to derive this to justify this actually, and yeah.
So the reason,
Mhm.
I'm still a little bit not clear. The reason why the asymptotics is not the usual asymptotics, is because you don't have a regular model.
No.
So your score function, the so-called the Neyman orthogonal score function, you have a nuisance function. You have a nuisance
Right.
function in your model.
Right.
That nuisance function is non-parametric.
Yeah, non-parametric, fully unknown.
Semi-parametric, so you're
Yeah.
looking at the likelihood score for semi-parametric model.
Right.
I see, I see.
Yeah.
Okay.
So yeah, that's why it's actually very challenging.
Right. So it's kind of like an influence function concept. a
Yep.
little bit.
Yeah, you can derive the
Little bit
influence function here.
function
Yeah.
Concept there.
Yeah, you can derive the influence function. Yeah.
All right.
But because we need I mean, the back to the original goal, we want to provide providers. But
Be surprised because semi-parametric model, there's a lot of work, different type of semi-parametric work. You need different type of effort to overcome the semi-parametric structure. But similarly to me, even though Neyman was my professor, he died, the year I entered Berkeley. But I don't know, he has a method so powerful,
yeah,
which allows you to have the general asymptotic theory. Is
Yeah.
that right?
I think the asymptotic theory is this is heavily rely on semi-parametric efficiency theory.
Right.
But I don't think Neyman has played a very substantial role in
No, I
semi-parametric.
don't.
No.
Because
Yeah.
even when I was a student there,
Mhm.
I think those professors wouldn't give the credit to him.
Yeah. Right.
So all the semi-parametric models, you have to have ad hoc type research,
Mm-hmm.
Otherwise, in the proportional hazards model, you don't even have to study it, right?
Yes,
Right.
Just
exactly.
use this kind of general tool. So I just wonder, to me, this is a little bit surprising,
Mhm.
you
Yeah.
know? So maybe, so I'm thinking probably your model has a particular structure, so you can take particular advantage.
I think it's the magic is in the partial linear.
Partial linear.
Yeah, partial linear. Yeah. Yeah.
Maybe it's a linear term plus something unparametric.
Right. Because
So
yeah,
that
I mean,
proportional hazard model, you don't have such a thing
Yeah.
because it's totally non-linear.
So is the partial linear structure can we consider like a single index model as a special case?
right. That's actually there is I mean, in terms of the model, there's a generalization, I think they call it constraint moment conditions model. And I think that has been used widely in econometrics.
Okay.
Yeah, but not I believe not a lot of applications in statistics. Yeah. Yeah. But yeah, single index model, that's a special case. Yeah.
Okay.
Yeah. Yeah. So okay. We did some simulation experiments. So a brief description of the setup. So we in the experiment we consider 5 providers basically, and provider 1 is the reference group, because you probably already tell that we intentionally dropped the indicator of f equal to 0. That was because of the identifiability issue. So we need to drop that. And that's also because I'm not sure whether you guys know the details, but let's say in a feed-forward neural network, and in the output layer, there is actually a bias term over there. So when you fit the partial linear model, you can treat that bias term as the constant term in say a logistic regression or a linear regression. So if you don't suppress the reference term, then you will run into the identifiability issue. That's why. So here we here basically consider 5 providers, but treating the first one as the reference, and we draw the number of the number of patients for each provider is drawn from a Poisson distribution. Basically, it's a count, right? So the mean is lambda. So we're going to vary lambda from I think 20 through 200, maybe 500 actually. So we have I think 12 covariates, and they're drawn from a multivariate Gaussian distribution. Nothing special, but here the G star, because it's a nuisance highly complex nonlinear function, this is what we did. It's a very complicated thing. And the provider indicator, we define the provider indicator. Basically, we use the C is a matrix. It's like a linear contrast thing. So C, Z, and you basically pick the one with the highest value, and then you transform the values using softmax. So that will give you a vector of probabilities. Then you pick the one with the highest probability, basically the index of that row. The highest, yeah, the row with the highest value, the highest probability. So that's how we define the provider indicator. And we have 4 actually provider specific effect because we need to drop the reference. So these are the true values for those 4 provider specific effects. And the Y is a binary outcome, and it was drawn from a Bernoulli distribution and given the, of course, outcome model. And some interesting results. So lambda equal to 20, basically it's a very small sample setting. Basically for each provider, you have about 20 patients, and in total you have 100-ish patients. So it's a relatively small data set. If you look at the bias, what's surprising is even in a very small sample setting, the DML approaches are actually very good. So I think in terms of the bias, because we use 2 different types of name and orthogonal functions, so that's why there's DML1, DML2. So, but the only difference is in the name and orthogonal score function. So the first one, LR, is logistic regression. FNN is the feed-forward neural network, basically a deep learning model. So if you look at the bias, so the bias is pretty big for the neural network model compared to the logistic regression. And if you look at if you go further down here, this CP is coverage probability. The double debiased machine learning methods are always the best. They are very close to 95%. And if you look at the other 2, they are either very large or very small, very, far away from the 95 nominal level. And if you consider larger sample size, I think the bias would be the difference in bias and absolute bias and the MSE there relatively, because the sample size is getting larger, so the difference is not that large, but the coverage probability, they are still very consistent around the 95% interval. It's yeah, the performance is pretty consistent. Yeah.
How do you get confidence interval from neural net?
Because you have so it's basically, when we fit the DML model, we also have the deep learning model, right? So we basically use that same model. So remember in the outcome model, here we have a linear term here.
Yeah.
Yeah. So we basically do some inference here. Basically treating other part as given.
Conditional on the neural net.
Yeah.
Okay.
Yeah. Yeah, very similar to a logistic regression, but the nonlinear part is, yeah, basically accounted for by the neural network. Yeah. Yep. Good.
So, but the idea is that you want to debias the, bias G star here. However, the target is you want to rank different hospital based on
Right.
gamma star.
Right.
And if gamma star is biased for every hospital. It's a relative metric you want to do. It's a compiling.
Right.
If they are ranked 1, 2, 3, 4, and then you move the value
Mhm.
to another range, they still have the relative ranking the same.
Maybe not. Maybe yes, maybe not. I'm not sure. So the debiasing process is with regard to the gamma star, not the G star. So I believe the G star would always be a little bit biased, but that's not the goal. I think, as you said, the goal is to have as good estimates as good as possible for gamma star. Yeah. Yeah, and so this is ongoing project. I basically get the simulations like a couple of days ago. I have additional, of course, things I need to do, but this is an important step. Basically, it shows that the DML is promising for the next step, basically providing providers, because we need accurate estimates of the provider effects. Yeah. So, any other questions?
And if the logistic regression performs well when the sample size is big.
Yep. So I think in terms of the stability, I think logistic regression is not bad, but still the DML approach is better than the logistic regression
Right.
for obvious reasons. I mean,
Yeah, the model is very non-linear, right? But
Yeah.
the logistic regression is actually pretty well.
yep, yeah.
I'm just curious for
Mhm.
the computational algorithm.
hmm
How complicated is that? The
I
score function when you write?
Yeah, I think thanks to PyTorch developed by Meta, I used that PyTorch, and I use PyTorch within R. I'm not sure you guys know that, but there's a R package basically integrating Python with R, and you can basically write your Python code and incorporate that into R, and
Okay.
yeah, it's like C++ and R, RCPP, something similar to that.
So complicated, but still manageable.
I think so, but I mean, in terms of the computation, I mean, I haven't touched the real data, but let's say if you have millions of patients,
Right.
it's definitely a different problem. I mean, you have to think about how to scale up the program so that they can handle
The
like
very large data.
yeah, probably Python is not good enough. No, maybe yes, C++ is the king.
No, but the Python should be very optimized.
Well, I honestly, I can give you a little bit of idea. So for the lambda equal to 500, I mean, we only have 5 providers. I think either on my laptop or on the server, if you run a single model, it took me about 6 minutes.
Yeah, I just don't think you can do better than Python. Like ordinary human beings.
But yeah, but you know what? There is a C++ version of PyTorch.
Which one?
C++ version.
This-
So PyTorch is written in Python, but they developed a C++ version,
Oh,
which is much faster, I assume.
Oh,
yeah.
okay, the Python version is not the optimized?
The optimized, but it's Python. It's not like
Still need a sequence.
Yeah, I just shocked. I thought they are still optimized.
yeah, they optimized, but it's not that fast. Yeah. I mean,
Okay.
because we need to do this cross-fitting procedure and involves many you need to fit dozens of neural network models.
Yeah.
Yeah, if say each hospital gets very large, of course it'll take a lot of time, and we probably need to rely on GPU for that.
Yeah.
I haven't used GPU for the simulations, but we can use that. Yeah. That should speed up each neural network model fitting. Yeah. But
I had never heard of C++ version of Python.
It- yeah.
Already, the behind the scene is already.
yeah, it is already there. Yeah.
Yeah.
But I think it's always a pain for me to code in C++. Yeah. You probably know that. Yeah. Yeah, it's a pain. Yeah. It's a huge pain. All right. So for now, I think I intentionally overlooked an issue because I let the reference predefine. I didn't talk anything about the reference. No, right? But actually in practice, especially in provider profiling, I believe not only me, but a lot of people believe that the reference is not very well defined. It's not like, well, in certain cases you want to compare you want to treat one provider as sort of the standard. Say we're at Hopkins, we want to compare, say, all hospitals in Maryland, we want to compare every hospital with Johns Hopkins Hospital. That's, of course, you can do that, but in some of the nationwide profiling programs, people are not doing that, not doing things that way. Like, for example, I was trained in Michigan, and people in Michigan, they evaluate kidney dialysis facilities across the nation. what Jack and Calvin has done, they basically, they previously they fit like a fixed effects model. And now, and then we have the provider specific fixed effect estimates, right? And then they take the median of all those estimates and use that as some sort of, in the null hypothesis. Okay, it's basically say gamma I is equal to the median of all gammas, whether that is true. So that's the null hypothesis. But why median is a good one? Well, median is probably better than mean because it's more robust. But if you have a nonlinear link function, median doesn't give you anything meaningful in practice, honestly. So actually, this is a interesting problem that is, I think, not properly resolved in the literature. So this is the second limitation. So previously, in the first part, we assume that we already define a reference. But now we're going to look into the issue where, well, we have no idea what the reference is. Is there a framework that we can use to develop? Well, the framework must be got to be very flexible so that you can design many different types of references you want, like benchmark providers. So I listed a few examples, like the number 2 I just mentioned. They use median provider effects in the fixed effects model. So I think the random effects model, Sharon Lee's Norman, they use basically the posterior mean as the reference. But why that is the one? It's maybe it's implementable. It's easily implementable, but maybe it does not make any practical. That doesn't have any practical meaning, right? That's the something 0 or whatever. Yeah. So there are some other ways of defining that benchmark or reference in causal models. As I said, if we treat Hopkins as the benchmark, of course, we can do that. Or we can do maybe a couple, say hospitals with patients over 5,000. I mean, many different ways you can, whatever you want to do. Or you can consider if you want to form a benchmark, because the goal is to improve the performance of providers, right? You do this over and over again every year, and you want to see performance improvement in providers. So another way of thinking this is, okay, can you define a reference, a benchmark, so that you can easily raise the bar, say every year, so that those hospitals are competing. They're trying to meet the higher standards. So in that way, you can improve the performance, right? So there are many different ways of doing this. So, but there's not a unified framework in the literature to accommodate all of these different needs, contexts, right? So this is another example that I did, basically evaluating OPO organ procurement organizations across the nation. I think there are 50. There used to be 58, but now maybe 56. So these are very simple stuff, nothing fancy here. Basically, we rank all the OPOs, and so we basically focus on a single one. This is, I believe, OPO 30. So if you look at this panel, this is for the white population. The performance is actually is above the national rate, right? So if you look at the same OPO, but if you focus on Black patients, then the confidence interval is is to the left of the national average. So anyway, there is also some sort of equity issue here.
Would you interpret it as bias, or they are actually doing better on like white as opposed to
So I didn't include an overall performance. So, but that'll be very similar to panel A. So the overall, basically, if you only focus on the general population, so you're going to overlook a lot of details here, right?
But this is risk adjusted, right?
Well, we did something very simple, very simple. That was like required by CMS. They didn't want us to do any risk adjustment. So of course there is of course you will, yeah, your argument is justifiable. We need to do some risk adjustment, but anyway, there is some disparities here, I believe. So this is the idea. We basically want to, we call this a design-based approach. So there are some assumptions, but these are very, I think, very simple or very straightforward conditions. Basically, first is we assume that a patient chooses their own provider based on their own characteristics, their conditions, their different types of provider, or their insurance. And the second one is the outcome would depend on, of course, the patient's basic conditions, and of course also depends on the care received by from the provider, right? So different provider differs here. So mathematically or more rigorously, we can have the bottom version. The upper one is like more reader friendly. So we introduced this process called reclassification. So the simple idea, the overall picture is to basically, okay, we have a data set. And let's say we want to construct a benchmark provider using this data set, but how we approach this is basically we draw patients from existing providers to form a new hypothetical provider. And we call this process reclassification because you reclassify certain patients from the existing hospitals to a new hypothetical hospital, right? So we reclassify for patients. So we basically need to introduce a random indicator here, R. So this R equal to 0. We call this reclassifier, by the way. So this reclassifier is equal to 0 if the subject is reclassified into the hypothetical provider. But if it is equal to 1, it remains in their original hospital. So this is something similar to the, in the missing data literature, people use the missing data indicator, but it's the other way. And with the original definition of this F is a little different from the one the first half. So we have F star here being to indicate those existing providers, and this F is defined as R times F star. So F is possible to be 0, but F star is not going to be 0. That's the only difference. So when R is equal to 0, that means the patient or the subject is being reclassified into the newly created hypothetical hospital or provider, and F is equal to 0. Yeah. And so, yeah, basically R is used to manipulate a patient's provider membership. This is the goal of this process. And we have additional conditions we need to assume. Well, the fourth one is not not always required, but the third one is required. So basically, when we reclassify patients, simply put, we cannot reclassify all patients from that hospital to the benchmark provider because we need to have at least a few patients that we can use to basically compare. Otherwise it all becomes the new hospital, right? That is not very useful. So the fourth one is actually very policy driven. So we call it blind list. So basically, let's say it really depends on whether we have the data, we have access to the data before reclassification or after reclassification. If we have the original data, basically, okay, we know after reclassification within that new provider, where those patients came from, right? We know where their original, which original hospital they are in. But if we assume that we don't have reclassification data, then we have no idea. We only know that those patients in the newly created provider, they gotta be in one of the hospitals, but we have no idea which one is the right one. So yeah, so mathematically, the positivity assumption is here, number 3, and number 4 is basically this one in gray. But as I said, number 4, you can relax that assumption. You can either use that or not use that. depending on different settings, because in certain cases, certain providers, they form a chain. They can be very influential. They can even influence the profiling results, believe it or not. Like in dialysis domain, there's a big company. They have, I think, at least 2,000 dialysis facility across the nation. It's like 1/4 of all the providers, all the facilities across the country. So they are very influential. They have lobbyists in Congress. Yeah. So, and the bad thing is when we introduce reclassification, it also introduces bias. So yeah, so here we have this proposition 1. When we do the reclassification, so this proposition basically summarize. How much time do I have? Oh, it's over. Okay.
Yeah.
Let me quickly wrap up things. So this is so the term in blue basically tell us what the bias. So if the term in blue is not equal to 1, I mean, in certain cases it could be equal to 1. If it is not, then it's definitely basically it's an evidence of bias, and we have actually different settings we can consider. So we haven't talked about, we introduced a factor, we introduced an indicator R here, but could R depend on the outcome? Could R depend on the covariates? Yes, they can. Could R depend on the provider identifier? Yes. So they can depend on a lot of things, or they can, I mean, in an ideal setting, it's independent of everything, but it's not very realistic, right? So this is the very unrealistic case where we have independence. It is independent of everything, condition on Z. So basically it says, okay, after reclassification, we can still fit whatever model we want, and there's no bias. That's very simple, straightforward. And this is a very simple example here. So basically this is basically a reclassification scheme, because that is the probability of R equal to 0 given Z, right? So it's but the expression, as you can see, it doesn't depend on any doesn't depend on the Y, doesn't depend on any provider indicator, right? It only depends on the covariate, right? So there are more complex cases when R is not independent of either F star or not independent of Y, and there are other examples. So the simple idea is here is you can reclassify patients from existing providers to form a new one, so that, okay, maybe one example is you can just pick one representative patient from each hospital to form the new hypothetical hospital, or you can maybe draw patients proportionate to their hospital volume, hospital size, right? Either way is could be useful. It's like, how we do the Congress election, right? In the US, we have Senate, we have House of Representatives, right? For the Senate, each state has only one representative, right? And for the House of Representatives election, it's like proportional to their population, right? Either way is possible. Either way is okay. So this is basically, equal representation. Basically, we only draw one patient, say or the same number of patients from each hospital, regardless of their size. Or you can do something more like proportional, I think, here. Yeah, this is actually proportional. Or you can maybe pick one. Yeah, as I mentioned, one representative hospital as the reference. And this one is relatively complex. So this is actually quite different from the existing literature. Maybe, I don't know, maybe Jesse, you're familiar with template matching in the literature. There are some people using that, but they claim that of course, they also want to form some sort of a reference group, but they said the template matching approach cannot depend on the outcome. But actually that's, I mean, if you have dependence on the outcome, that's actually a way to improve outcome because you can somehow increase the bar. You can always do that by like purposefully recruiting more patients with better outcomes to form that reference, right? So that way you can, if you want to raise the bar, go for it, right? You can have more patients with better outcomes, right? So that, of course, that reclassification process depends on the outcome, right? So this is the setting where we have the outcome dependent representation.
So the selection is not for the purpose to understand the population, right?
So
Because, outcome dependent sampling, is an area of research.
Mhm.
But I think the usual concept, outcome dependent sampling is that for some reason, for example, you need to select people with higher income,
right.
or, some kind of a outcome.
Oh, rare
dependent.
outcomes.
Right.
Yeah.
Right, even case control, you can think of it as
Yeah.
outcome
Yeah.
dependent
Case
sampling.
control. Yeah.
But the purpose, the usual purpose is still to understand a given population, but this is not what you are thinking of.
No, it's different. Yeah. So here is basically there's an example. It's a little involved in math, but the final goal is to so we're trying to calculate this odds ratio. The odds ratio is before and after reclassification. So we want the odds ratio to be basically less than 1. So it means after reclassification, the reference group or the benchmark has better outcome because we want to improve the outcome, right? You want to compare your hospital with the reference, and if the reference is getting better and better, then it's some sort of incentive for you to improve your outcome to match your reference, right? Yeah, that's the goal of this example. And you can do that by, of course, manipulating the proportion. Well, there are some details here, but that's basically the idea. I think that's probably all I had, and this is like a quick summary. So 2 parts. The first one, we basically developed the DML approach, and we showed that it's better than the neural network, naive neural network. Of course, the logistic regression as well. And we introduced a design-based approach. Basically, we want to develop a very flexible benchmarking approach in provider preference. And the next step would be to incorporate these two together, because I think I intentionally left something unresolved in the first part, right? Of course, some other things we need to address. We haven't talked about applications, and we need to do some real data analysis, of course. And there are some other extensions, I think interesting extensions, of course. I believe the design-based framework could be extended to lifetime data settings, but it's probably not that straightforward because in this case it involves time, and it's probably not that straightforward because in the longitudinal setting you only sample one observation. Maybe that's very easy, but I don't think time to event data would be that straightforward, right? And last one is something that I'm currently working on, something related to provider profiling, but not quite related to the approaches that I've been discussing. It's more like we want to do some unsupervised machine learning stuff, but there is one, I think, recent paper called causal k-means clustering, and maybe you guys also heard about double dipping in clustering. I think Danila Witten, they developed some interesting things. It's basically, if you use the same data, you split data into clusters, then you do the inference, say you want to compare the means of different clusters. But that is based on you already identify those clusters. So it's like you probably run into some issues. I think they have some results saying that the p-values are not valid. The inference is not valid. So yeah. So the next this is still ongoing, and we just started this with Vahid, and we believe that there is something very interesting here to to do some post-clustering inference here. It's not very easy, yeah, as well. But yeah, that's I think that's probably all I had. So this is people that I've been working with, 3 postdoc and a couple of students actually, but only one is involved in these projects, and some collaborators at NYU, and actually one recently left NYU to start a company. So yeah, acknowledgements, and that's all I had.